Hello everyone, my name is Kathy Jo Stentz, and I'd like to welcome you to this webinar presentation on aligning intensive outpatient services and partial hospitalization services to the ACAM criteria. This presentation has both audio and visual, and in order to access the slides, you must join this presentation via the specific Skype link that corresponds to this particular webinar on the presentation schedule. You can access the schedule by visiting www.ddap.pa.gov. Then, by selecting the For Professionals tab in the upper right-hand corner, and then navigating to the ACAM transition page. This presentation will provide a high-level overview of the documents recently released on 2.1 intensive outpatient and 2.5 partial hospitalization services. There are two documents for each level of care, the services by service characteristic and a self-assessment checklist. A third document, the Pennsylvania Expectation Addendum, will also be reviewed today. I would encourage you to have all of the documents available during the presentation, since we will be referencing them as we go through today's presentation. The documents were previously sent out via DDAP's listserv, but they are also available on our website, and you can access them from our website now. And to locate them, use that same web address that I just gave you, www.ddap.pa.gov. Go to the For Professionals tab, and then navigate to the ACAM transition page. The service description document is actually an abridged resource of the information presented in the ACAM Criteria 2013 text, and the self-assessment checklist is a resource that will assist providers in self-gauging where they are at in the alignment process. These documents are a resource for service alignment. However, they should in no way be a substitute for completion of approved training on the ACAM criteria or having a thorough awareness and use of the ACAM Criteria 2013 text. Please note that this presentation today only includes information specific to Level 2 services, and additionally that DDAP and DHS are still working on finalizing details about co-occurring services. Therefore, specific details about the delivery of co-occurring capable and co-occurring enhanced services will be addressed at another time. There is a lot to cover in this presentation. Therefore, questions regarding today's information should be submitted through email to ra-daasam@pa.gov. Questions and answers will be addressed through subsequent webinar sessions that will be held on December 1st and December 4th, and through a written FAQ that will be posted on DDAP's website to follow. As a side note, while the various documents for each of the levels of care are being disseminated separately, all of them will eventually be combined, along with the guidance document and any changes that have been made along the way, into a single combined document for ease of reference. Currently, all ACAM resources relative to Pennsylvania are located on the DDAP website. We have been working on transitioning to the ACAM Criteria 2013 over the past 3 years and have accomplished a great deal over this time. In aligning with the criteria, we are supporting Pennsylvania's implementation of its 1115 demonstration waiver required by the Centers for Medicare and Medicaid Services, CMS, for continued medical assistance funding. We are moving to an evidence-based practice assessment and service delivery criteria, and we are working toward overall system-wide improvements. Much has been accomplished toward these goals. Many trainings have occurred during this time frame, with over 8,700 individuals completing the 2-day in-person ACAM skill building training, with additional individuals taking the Change Company's online ASAM trainings approved in January. Guidance documents have been published and released on various occasions, FAQs have been posted, and residential providers have participated in a preliminary level of care designation survey. While agencies have been trained and have been required to use the criteria for level of care assessment since January 2019, we have not yet directed the official alignment of service delivery to coincide with the criteria. But we are now ready to move our system forward with this aspect of alignment of service delivery with the ASAM criteria, and that takes us to next steps. DDAP has been working collaboratively with the Department of Human Services in an effort to support service providers and payers with alignment and aligning the delivery of services as described in the ASAM criteria. The alignment focuses on setting, support, staff, therapies, assessment and treatment planning, and documentation. Providers should begin working towards alignment in the various areas identified in each document and this presentation immediately, but incrementally as needed to appropriately address each item. DDAP has posted a timeline on its web page to assist with proposed completion times. Please reference this resource for anticipated progress of alignment with the criteria moving forward. Foundational to the alignment process is understanding that the licensing requirements for each level of care are minimum standards for operation. A drug and alcohol license is absolutely required for operation. Alignment with ASAM criteria is an expectation of quality required as a contracted provider receiving state or federal funds, either through the SCA or Medicaid, that goes beyond minimum licensing requirements. A provider will not be able to hold a contract to receive public funds without aligning to the ASAM criteria. And let me say that Medicaid also includes health choices funding. As stated very early on in the move to using the ASAM criteria, doing such has been both an event and a process. There have been specific dates by which certain aspects of alignment were to be completed. For example, all assessments, continued stays, and discharges are to occur using the placement criteria. That's already been completed. The process continued with ongoing training and preparation for the next phase of transition and alignment, and now we are ready to proceed with aligning our services to the descriptions as outlined by the criteria. There are target dates for overall completion of the alignment of services to the ASAM criteria as noted on the posted timeline. Expected timelines for completion, as I said, are on the DDAP website, many of which are July 2021. Some of the expectations will be able to be met with relative ease, while others may require additional effort. In all cases, DDAP and DHS will do our best to support our provider network in aligning with the criteria, as we believe in the importance of working together to improve our system and to deliver an even higher quality of service than we have been accustomed to in the past. It is important to add that alignment efforts will continue beyond July 1st, 2021, including capacity building, technical assistance, and monitoring. Hopefully, if you did not have the documents in hand, you have them now. This slide shows you a miniature version of what we will be referencing during this presentation. Let me point out that the documents for every level of care do have a similar layout that corresponds with how the information appears in the ASAM text, flowing through settings, support systems, staff, therapies, assessment and treatment plan review, and documentation. While each level of care has the same categories of services and even many overlapping requirements, of course, distinguishing criteria exist for each level of care. As you work to bring your program into alignment, you will want to use the documents applicable to the levels of care delivered in your program in tandem with the ASAM criteria text to fill in any gaps. The self-assessment document and the Pennsylvania Expectation Addendum will be especially helpful in aligning your programs to the criteria. Before we look specifically at the documents and discuss alignment of services to the ASAM criteria, I'd like to compare and contrast ambulatory treatment service hours as they currently exist. This will help demonstrate the changes that will result from aligning the ASAM criteria. As indicated on the slide, hours of service for all ambulatory treatment services will increase under the ASAM criteria description of services. The diagnoses and severity of symptoms described in the ASAM admission criteria that have been in use for level of care determination in Pennsylvania for over a year will become more appropriately addressed as we align our services to match the admission criteria. The hours in the 1.0 outpatient and 2.1 intensive outpatient levels of care allow for a range of intensity of programming depending upon individual need. Outpatient hours will increase from up to 5 hours at most to fewer than 9 per week. Intensive outpatient, which is currently delivered at 5 to less than 10 hours a week, will increase to between 9 and 19 hours of treatment per week. Partial hospitalization increases from at least 10 hours to at least 20 hours per week. You will see as we move through today's presentation that the increase in hours is not an arbitrary delineation of time, but is necessitated by admission criteria that demonstrate a higher degree of need and therefore require a higher intensity of service. So with that brief review of existing delivery of services, let's review how the ASAM criteria describes IOP services. These services are provided in freestanding facilities which can be found in a variety of different settings that must meet Pennsylvania licensure requirements. The IOP level of care falls under the outpatient license. That is to say, there is not a separate distinct license for intensive outpatient services. The supports that are essential at an IOP level of care include medical, psychiatric, psychological, and laboratory and toxicology services. In most cases, rather than being provided on-site, access to these services will occur through affiliations with providers outside the agency. If any Dimension 2 biomedical issues exist, they should be noted on the treatment plan and with proper consent, referral to, and consultation with an individual's primary physician should be made as appropriate. Additionally, it is important that clients have access to emergency and crisis services by telephone 24 hours a day, 7 days a week. Some facilities may have a rotating on-call service manned by facility staff. Others may opt to utilize crisis management to field 24-hour calls, while others may utilize a hotline number, be it the state hotline or a county-established one. Access to pharmacotherapy applies to all levels of care. Individuals cannot be denied services based upon their use of FDA-approved medications to treat substance use disorders, and all service plans are to be individually tailored to meet the needs of the individual. Pharmacotherapy is the standard of care for opioid use disorder and is an evidence-based practice and should be available while a person is engaged in services, either directly or by referral or through coordination. All clients receiving services are not mandated, but are entitled to receive case management services. Case management is defined as a collaborative process that assesses, plans, implements, coordinates, monitors, and evaluates the options and services required to meet the client's health and human services needs. DDAP is working with the SCAs to strengthen case management and services as a distinct and separate service from the clinical process so that individuals have the support that they need while allowing clinicians to focus on the therapeutic process. The clinician and case manager should work collaboratively along with others to form the interdisciplinary treatment team. Regarding staffing, the requirements for on-site staff that are outlined in the Pennsylvania regulation remains applicable as a minimum standard when aligning to the ASAM criteria. Minimum education and training requirements remain intact for hiring clinical staff. Any specialized staffing, such as medical or mental health staff that is part of the multidimensional treatment team, will likely be adjunct staff or collaborative team members rather than on-site staff, but should be active members of the treatment team nonetheless. For all staff, any areas of clinical specialty should be noted on the individualized staff training plan, and a record of completed population or service-specific training should be maintained. Since evidence-based programs and interventions are foundational to the delivery of quality care, training records should include those EBPs or therapies that are embraced by and routinely provided at the facility by all relevant staff. All clinical staff should have a foundational knowledge of motivational interviewing and the stages of change, since assessing readiness or stage of change is foundational to applying the ASAM criteria. Moving forward, there will be an expectation that clinical staff be able to demonstrate proficiency with motivational enhancement and engagement strategies appropriate to an individual stage of readiness to change. Given the intensity of the needs that may be treated at this level of care, it is important that many staff be cross-trained to understand the signs and symptoms of mental health disorders and to understand and be able to explain the uses of psychotropic medications and their interactions with substance use and other addictive disorders. There will be specific requirements for co-occurring capable and enhanced services that will be presented at another time. But initially, at minimum, clinical supervisors will be expected to be well-versed in co-occurring issues to appropriately consult with and provide oversight to their staff regarding appropriate care for issues in Dimension 3. Moving beyond the minimum requirements of the Pennsylvania regulations, staff will also need to either have professional licensure or those certifications issued by the Pennsylvania Certification Board, or PCB, applicable to the assigned duties of the staff, or be working toward these qualities of standards after hire. This requirement is more fully outlined in the addendum document, as will be discussed in more detail later in the presentation. A guiding principle of the ASAM criteria is moving away from program-driven to both clinically driven and outcome-driven treatment. Treatment should be individually based upon the needs identified in the multidimensional assessment and should be therapy-based and not curriculum-driven. IOP services were previously defined as, at most, 10 hours per week and were usually primarily group therapy sessions with a combined individual session or two during the week. The ASAM criteria defines IOP services as between 9 and 19 hours of therapy sessions. This may seem like a drastic change for IOP to move from 5 hours per week to between 9 and 19 hours. However, it is important to point out that hours are designated as a range between 9 and 19 hours and should be delivered as determined by the needs identified on the 6-dimensional assessment and outlined on the individualized treatment plan, and not through a programmatically designed course of care. In other words, not everyone admitted to IOP should receive a set number of hours of counseling. Not everyone is going to need 9 or 19 hours of treatment. Rather, an individual should receive services at the quantity and frequency between 9 and 19 hours that best meets his or her needs as determined by the individualized treatment plan. Intensity of engagement and service delivery can and should be adjusted. For this reason, it is likely that many, if not most, of those individuals who have been served in our historically defined partial hospitalization programs will be able to be appropriately served in an ASAM-aligned intensive outpatient program. Delivery of services should be what is therapeutically and individually needed through both individual and group sessions. While IOP is licensed as an outpatient service and regulation indicates, as a minimum standard, a staff-to-client ratio of 1:35, DDAP and DHS have had to consider a quality standard in aligning to the ASAM criteria and to comply with the 1115 requirements. Since the admission criteria for the IOP level of care is for individuals with a significantly higher level of need than those in standard outpatient services, it has been determined that the caseload should reflect that need, and therefore fewer clients should be served by each counselor. Interestingly, this is not a new insight, as a staffing ratio of 1:15 was recommended in Pennsylvania's previous placement criteria as best practice for the delivery of intensive outpatient services. However, adherence to this recommendation was seldom, if ever, implemented. As our system aligns to the ASAM criteria with its service delivery, including the increased hours of service, the focus of the delivery of improved individualized therapeutic care, and a more rigorous assessment and treatment planning process, DDAP is revisiting the staffing ratio and requiring the higher extent of clinical oversight by instituting a ratio of 1:15. This is especially important given the intensity of the service and the level of need represented by those individuals being treated in this level of care. DDAP foresees some concern by the field regarding the potential need for increased staffing with this new requirement. However, along with the long-term gain that the added clinical oversight will accomplish regarding the quality of services, it is also likely that the anticipated increase of admissions to IOP that will result from the expansion of this service, including the delivery of service to those individuals once deemed appropriate for partial services, the staffing changes should be supported. Group size across the continuum of care will be a maximum of 12 individuals for therapeutic individuals. Educational didactic presentations can include additional individuals. Skilled therapeutic services should include group and individual counseling, medication management, family therapy, educational groups, occupational and recreational therapy, all of which must be tied to and justified by the assessment and individualized treatment plan. Just as the number of service hours must be determined by individual need, so do the therapeutic interventions. Evidence-based programs and interventions are foundational to the provision of quality care. And while educational efforts will be a part of care, clinical interventions must be therapeutic in nature and not primarily curriculum or psychoeducationally driven. For example, but not limited to, the delivery of therapies such as cognitive behavioral therapy, rational emotive therapy, EMDT, etc., should be delivered within the therapeutic setting and provided by staff members appropriately trained to deliver these therapeutic modalities. Motivational enhancement strategies are foundational to the delivery of services. As indicated, while the majority of IOP providers will not have physicians on staff, there is still a need to treat an individual holistically and, whenever necessary, to engage the individual's healthcare provider as a member of the treatment team. With appropriately signed consent, referrals to and contact with primary care physicians should occur, and compliance with directives from the healthcare provider, including medication monitoring, must happen. Case management can also play an important role in coordination of care. Because substance use disorder impacts the family as a unit, services and counseling with family members is required whenever possible. This is beyond educational sessions. If individuals are hesitant to involve family members into the sessions, therapists should begin to explore the reasons why, as this may be a therapeutic exercise for the individual in building the confidence to begin to open up to persons whom they consider family, building bridges and mending severed relationships in the process. As previously stated, an individual cannot be denied access to pharmacotherapy, and whenever possible, coordinated efforts should occur to allow for continuity of care for an individual who is on an FDA-approved pharmacotherapy while engaged in IOP services. The initial six-dimensional level of care assessment should be reviewed with the individual and utilized to formalize a complete biopsychosocial, which is then used to prioritize the needs and develop a treatment plan with the individual. Working with the client in identifying the strengths, needs, and preferences, the treatment plan should be prioritized by risk. Assessment will need to reoccur regularly during the therapy process to accurately reflect progress or current issues that develop over the course of care. Clinicians should reference page 110 of the ACAM criteria text, as well as the Pennsylvania guidance document regarding timeliness of reassessment. While specific co-occurring details will be presented in the future, it is important to note that assessment for any mental health conditions should be determined both initially and ongoing to determine the need for adjunct or specialized co-occurring services. The level of care assessment must be done by an independent source or show evidence of neutrality. Additional details are included about this in the Pennsylvania Expectation Addendum, which we will discuss later in the presentation. The treatment plan must be completed collaboratively with the individual and should reflect his or her personal interests and goals. Patients should have a copy of their current treatment plan, and it should be actively used as a resource or roadmap during each individual and group session and to assess progress. Individualized progress notes should reflect the treatment plan, including the patient's response to the therapeutic interventions or treatment modalities used and any amendments made to the plan. Progress should be documented in notes that describe each contact with the individual and how the treatment plan was implemented and the individual's response to the intervention. Progress notes should be completed as soon as possible following the session to avoid lost content. In fact, it is often helpful to summarize the individual treatment session in writing while still with the individual as a mechanism of review and to present the next steps in the plan that are to be addressed. Progress notes should reflect the treatment plan, progress, adherence, and adjustments or updates made to it. So that takes us through a high-level review of the service characteristics document. Let's briefly review some of the characteristics of the self-assessment checklist. The provider self-assessment checklist includes elements for alignment with the criteria. In addition to the self-assessment, as we progress with service alignment at the state level, there will be a monitoring progress in place to affirm the self-assessment completed by providers and that alignment with the criteria has occurred and is maintained. So, looking at the blue square on page 1 of the self-assessment checklist covering the setting characteristic, a provider would read through each numbered item in the block and place a check mark in the corresponding red circle to indicate that this element already exists at the facility. Those items or red circles that remain unchecked will need to be addressed in order for the program to be fully aligned with the ACAM criteria. Looking through items 1 through 4 in this list, as well as the list under the subsequent headings, you will see that in many instances, alignment requires the establishment of policy and procedures for many of the everyday practices that your program likely already has in place. In this case, items number 2 and 3, written policy for program admission and transition and discharge, and admission criteria, should hopefully already be in place. A key item in this checklist is item number 4, consistent evidence of a variable length of stay based upon patient need. There should be no designated time or length of an intensive outpatient program. For example, there should be no Sunnyside's 6-week intensive outpatient program. Program intensity, or hours per week needed, and duration, or length of stay, should be determined on an individual basis by assessment and need. Therefore, individuals with greater need may require more hours of service per week and receive the upper range of service hours. This would likely be those individuals who heretofore were in pre-ASAM criteria aligned partial hospitalization programs. There are 15 characteristics to self-assessment to self-assess under the heading of support systems. Although the checkbox appears in 2 segments on the slide, that's so we could fit it on the screen. In the document, this and other assessment checklists appear as a single box. Many of the 15 assessment points under support systems have to do with policy and procedures for collaborative care or referrals for service. As stated earlier, some of these supports will be provided directly by program staff and some by affiliation and referral. Policies and procedures should exist when referrals for concurrent services need to occur and how these collaborative services will be delivered. MOUs and letters of agreement should exist where necessary. Additionally, a provider's plan for addressing emergencies with clients must also be addressed in policy and procedure. The items emphasized in the staffing self-assessment checklist include areas such as policies and procedures that outline staff responsibilities, required credentials, etc. It also includes the need for job descriptions. As stated earlier, we will discuss the new requirement about credentials a little later in the presentation. As indicated, there must be evidence of variable lengths of stay based entirely upon individual need, which will be different for each patient. Treatment services may include individual and/or group counseling, motivational enhancement, family therapy, educational groups, occupational and recreational therapy, psychotherapy, addiction pharmacotherapy, and other therapies. Programs will need to evidence that this array of services exists but are delivered on an individual basis. Not everyone will need every service offered or in the same amount. You will notice this assessment checklist includes policies for staff trainings and verification of trainings applicable to services and therapies delivered at the program. Staff must be appropriately trained to meet the needs of the populations they serve and to engage in the services and modalities utilized in the clinical process. Much of what is addressed in the 14 elements of the assessment and treatment plan review is likely already occurring in your facility. So I'll highlight those most likely to be areas that will need some adaptations to align with the ASAM criteria. There are several items in the list that require having policy and procedure to formalize that which your agency does in everyday practice to align with the criteria. Otherwise, item number 3 discusses the need for an independent level of care. Item number 7 indicates that a physical exam is conducted as determined by an individual's medical condition. While physical exams are not required for everyone at admission to outpatient, if someone is indicating physical complaints or obviously has medical issues that are not being properly attended to, an appointment and follow-through with the primary care physician or a referral to a healthcare facility if the client does not have a doctor is warranted as part of the treatment plan and the delivery of holistic care and to address Dimension 2 biomedical issues. Engaging in an ongoing assessment process, as noted, the ASAM text on page 110 indicates that regular assessment is necessary in order to determine if an individual remains appropriate for the level of care. It's also important to note that for ongoing assessment, clinical staff will be expected to conduct these types of assessments. It is only the level of care determination that needs to have evidence of neutrality. Again, with the documentation checklist, providers will go through this list and check off the items that already exist in their program, as well as determining what areas require attention in order to come into alignment with the ACM criteria. I will remind you that while the Pennsylvania regulation provides mandated timeframes for when treatment plan reviews and updates must occur, if an individual circumstance warrants a review and change prior to the scheduled formal update, it should occur as often as necessary to be relevant in meeting the client's needs in the here and now. So with that overview of the 2.1 documents, let's move on to the 2.5 partial hospitalization services. As you know, partial hospitalization programming is licensed separately from outpatient and intensive outpatient services. Despite partial hospitalization having distinct Pennsylvania licensing requirements, the service as described by the ACM criteria is much more intensive than that which is outlined by the Pennsylvania regulation. Therefore, it is important to state as a reminder that Pennsylvania regulation serves as a minimum standard, and in moving toward alignment with service delivery as outlined by the ACM criteria, the service will be quite different from what we have historically known. So, in moving on to the service description document for partial hospitalization, we first find a discussion of the supports. We see that they are similar to IOP, medical, psychiatric, lab, and toxicology services, but the significant difference is that these services are typically provided by direct access rather than by referral. It is also a requirement that partial have the ability to access psychiatric and other medical consultation within 8 hours by phone and within 48 hours in person. Pharmacotherapy and medication monitoring are also a required service at this level of care. Like IOP, emergency services are important, especially given the instability of those individuals engaged in services at the partial hospitalization level of care, as is having direct affiliation with or close coordination through referral to more or less intensive levels of care. Case management remains an integral aspect of this level of treatment. As has historically been the case and applies to all levels of care, staff must meet the minimum education and training requirements for hire as established by Pennsylvania regulation. Nothing has changed with this. Once hired, there is an expectation that staff will be working toward credentialing and be appropriately trained to deliver the therapies and services delivered. According to the admission criteria, individuals who require hospitalization services are exhibiting significant need for stabilization. Across the dimensions, this is evidenced by decompensation and the inability to maintain behavioral stability, distractibility, and general anxiety that impacts daily functioning, or suicidal depression, or risk of endangering self or others, lack of impulse control, inability to postpone immediate gratification, with deterioration of functioning without close monitoring. With these admission descriptors, it becomes clear why the ACM criteria indicates that cross-training in mental health is imperative for this level of care, why access to specialty services need to be more immediate, and why a need for greater intensity of service as compared to intensive outpatient is necessary. The staff-to-client ratio, as outlined in Pennsylvania regulation for partial hospitalization, is 1 to 10. As opposed to the 9 to 19 hours of structured programming several times a week offered through intensive outpatient, partial hospitalization offers a minimum of near daily engagement with 20 or more hours of service per week. Services are still individualized rather than program or curriculum driven, but they are likely to occur over a significant portion of the day through intensive engagement and intervention. Also, as you see on the slide, services and therapies for partial hospitalization are better geared to meet needs identified in dimensions 1, 2, and 3, which warrant daily monitoring or management. The requirements for assessment and treatment plan review are similar to that which were discussed for IOP. There is a need for an independent level of care assessment or evidence of neutrality if done by the treating provider. Assessments must reoccur frequently as suggested on page 110 of the ACAM text, weekly for participants in partial hospitalization. While regulation indicates the need for treatment plan review and updates to occur every 30 days, again, please remember that this is a minimum standard, and ACAM requires that treatment plans are actively utilized and are updated as frequently as needed to be relevant to the therapeutic process. Documentation remains pretty straightforward and as previously discussed. Providers will use the self-assessment checklist for partial hospitalization as a mechanism for self-gauging where the program is at in the ACAM alignment process. Providers will need to go through every item under each of the subservice characteristics to determine where they're at or where they're already meeting those areas, or to find areas where additional work is needed to come into alignment. I will briefly highlight some of the ones most likely to be areas of biggest challenge for the partial hospitalization programs. While all of the items in the setting checklist are important, again, the item to bring to your attention is that there must be consistent evidence of a variable length of stay. No program should be defined by its length of stay. For example, no program should be indicating that it has a 3-week partial program, or that every individual in the program, in the partial program, gets 21 hours of service. Those items on the support systems checklist that most likely will need some work to come into alignment for most partial providers are as follows. Item number 1. The availability of medical, psychiatric, psychological, lab, and toxicology services. Item number 2, availability of medical and psychological consultation within 8 hours by telephone and within 48 hours in person. Items 3, 4, and 5 also have to do with availability of this staff and services and related policy and procedure. The remaining items pertaining to policy and procedure will also likely require effort, since these areas of service and support are not currently required and are not likely part of current services. Staffing levels at the partial hospitalization program, once aligned with the ACAM criteria, calls for more specialized staffing by affiliation, as well as more highly trained and credentialed staff on site. Staff must be cross-trained on the signs and symptoms of mental disorders and the interactions of psychotropic medications with substance use disorders, and there must be evidence of a training program offered for staff in this regard. Key to the differences in expectation with the alignment to the ACAM criteria regarding therapies is the increase in hours or intensity, as well as the type or variety of modalities in which therapy is presented, and evidence that all services are delivered in an individualized manner according to need. A range of evidence-based treatment services and description of these services will need to be available and provided by skilled clinicians. Skill will need to be demonstrated through training plans. In addition to therapy that engages the individual, treatment will also need to include the family. All these elements will need to be represented in policy and procedures as outlined in items 1 through 14. Key alignment to the ASAM criteria in the area of assessment and treatment planning is individualization, planning based upon 6-dimensional assessment and reassessment, having policy and procedures for updating treatment plans, which will likely need to occur much more frequently than outlined by regulation for plans to be reflective of the changing needs of the individual. Again, the delivery of care that is outlined in policy and procedure that is likely not already written will need to be developed in order to become aligned, with the ASAM criteria. And lastly, for the self-assessment checklist, the items regarding documentation are fairly self-explanatory. Before proceeding onto the addendum document, I'd like to pause and revisit comparison information about IOP versus partial hospitalization treatment that was discussed throughout this presentation. As you can see, in addressing only hours of service, both levels of care have a significant increase. For IOP, the range of hours increases between 4 and 9 hours from the currently defined service hours. As is currently the case, service hours are flexible to accommodate work and family schedules and can be day or evening hours or even include weekend participation. IOP allows skill acquisition to be tested in the real world. Folks will often do IOP and then also keep and maintain their regular daily schedules of work and home responsibilities. Partial has an even greater increase of 10 or more hours, taking the current 10 hours of partial hospitalization to 20 or more hours of service. These hours are delivered near daily, most likely not on weekends, but even then, some places are offering weekend hours, in a model that more closely resembles day treatment, where an individual would spend a significant portion of the day in engagement and intensive interventions, and unlikely doing treatment plus work. To understand the necessity of hours of service, it really helps to dig a bit deeper into the differentiations made in the ASAM text relative to the needs addressed and the level of function. The chart on pages 175 and 176 of the ASAM criteria text provides a good overview, and I've highlighted some of the differences in red from that chart, along with additional references from the ASAM text on this slide for us. So going through the various dimensions, a person appropriate for intensive outpatient services is only at minimal risk of severe withdrawal symptoms, where an individual appropriate for partial hospitalization may be at moderate risk for withdrawal symptoms. For Dimension 2, biomedical issues are stable for admission into IOP, whereas if biomedical issues exist for partial, they may be sufficient enough to warrant medical monitoring or management, but won't interfere with treatment. In these two areas, Dimension 1 and 2, acute intoxication withdrawal potential and biomedical conditions and complications, we see the difference between IOP and partial hospitalization being the likelihood of on-site medical staffing and more ready access to healthcare professionals within partial hospitalization. A pivotal dimension in determining intensive outpatient versus partial hospitalization is dimension 3. Emotional, behavioral, or cognitive conditions and complications. As is referenced throughout the text, some thought disorders, anxiety, guilt, and/or depression may be related to substance use problems and not to a diagnosable mental health condition. At times, co-occurring emotional, behavioral, or cognitive conditions may be stable. If either of these scenarios is the case, we see that IOP could be an appropriate setting to address or monitor these Dimension 3 needs without them being a distraction to recovery. However, the descriptors for Dimension 3 admission criteria for partial hospitalization indicate that an individual cannot maintain behavioral stability, with examples such as distractibility, general anxiety, etc., such that these symptoms impact daily functioning, or there may be suicidal depression or risk of endangering self or others. Individuals are emotionally or behaviorally unstable and need near daily intensive engagement and programming to avoid hospitalization. With regard to readiness for change, or Dimension 4, intensive outpatient is appropriate for someone who has had variable engagement in treatment, is experiencing ambivalence, or has a lack of awareness of SUD or mental health problems, and requires a structured program several times a week to promote progress through the stages of change. Whereas readiness to change for an individual in partial hospitalization demonstrates poor engagement in treatment, significant ambivalence, or a lack of awareness of substance use disorder or mental health programs that requires a near daily structured program and intensive engagement in services. Dimension 5, relapse and continued use, are similar for IOP and partial. That is to say, the individual has a high likelihood of reoccurrence or continued use. The difference is the level of intervention needed to mediate the issue. A person may need close monitoring and support offered by IOP, which can be intensified within the range of hours and services offered within this level of care. In IOP, a person's individual treatment planning can be modified to increase hours and supports, to include medications to assist with the impulses and cravings to use, and even a psychiatric evaluation to determine if there's an underlying undiagnosed or untreated mental health condition or disorder that is impacting an individual's recovery attempts. Chronic reoccurrence of use alone is not a sole indicator of the need for partial hospitalization. Rather, assessment would need to indicate that the near daily intensive monitoring and support of partial hospitalization is necessary for stabilization. As far as the recovery environment, or Dimension 6, the distinction between these two levels of care is that in IOP, an individual requires support and structure to cope with his or her environment. And in partial hospitalization, an individual requires relief from his or her environment. The need for housing is not a standalone admission requirement for any level of care. Considering all of the dimensions as a whole picture, both IOP and partial are intensive ambulatory levels of care. Upon alignment with the criteria, both will offer a range of hours and services that extend beyond what our system of care has historically provided. With IOP services ranging from 9 to 19 hours, a significant amount of treatment and support can be offered, but not the all-day intensity of partial hospitalization, with the intent to address the biomedical or emotional or psychiatric decompensation and instability that has been described. In short, a good rule of thumb is IOP is for monitoring and supporting. Partial hospitalization is for managing and stabilizing. Hopefully, this brief overview of the differences of the needs that would be addressed in these two levels of care will assist us as we continue to proceed through our discussion in differentiating the two levels of care. As you can see, overall, some of the most notable changes and enhancements resulting from the alignment to the ASAM criteria impact these two levels of care. And in fact, providers of partial treatment will likely find themselves needing to make a decision about how to proceed with the delivery of services. They will need to determine whether they will do modifications to hours and align with the ASAM criteria and changes to deliver IOP services that will essentially allow them to continue to provide services to a similar population with similar needs as they have historically served in pre-ASAM partial hospitalization, or they will need to decide to enhance their staffing and services to align with the ASAM criteria for partial hospitalization to treat individuals with co-occurring needs and those in need of significant stabilization. For programs that will be transferring their services to intensive outpatient services, if you do not already have an outpatient license, you will need to obtain one. You will want to contact DDAP's Bureau of Quality Assurance for Prevention and Treatment Division of Program Licensure to inform them that you will be relinquishing your partial hospitalization license and working to obtain and transfer your current delivery of services to an outpatient license. You will be advised how to do so with as little disruption, if any, to services as possible. If you already have an outpatient license, you will need to work to align your services according to the IOP service description and self-assessment checklist reviewed during this webinar. If you desire to fill the service gap through the delivery of ASAM-aligned partial hospitalization services and wish to maintain the PHP activity on your license, you will need to utilize the service description and self-assessment resources for 2.5 partial hospitalization programming to assist with the alignment process. DDAP plans to work with providers who will be aligning their partial hospitalization services to the ASAM criteria in order to provide specific support and to ensure a seamless transition with as little impact to patients or providers as possible. Therefore, we ask that you let us know of your intent to provide ASAM-aligned partial hospitalization services by contacting us and letting us know about this via the ASAM resource account, which is ra-da-asam@pa.gov. All you need to do is shoot us an email and let us know that you intend to deliver ASAM-aligned partial hospitalization program services. Moving on to the Pennsylvania Specific Expectations Addendum information, let's discuss staffing credentials first. DDAP embraces the rich heritage of lived experience that has held a long presence in our treatment field and acknowledges the benefit of licensed clinicians as described in the ASAM criteria. By striking a balance of education and training that can be acquired through the certification process, we will continue to have a gateway for those in recovery or those who do not have graduate degrees to gain experience through a mentoring process, while at the same time more fully embrace the credentialing process that already exists in the state through the Pennsylvania Certification Board. Staff hired prior to July 1st, 2021 will not have to meet this requirement as long as they remain in the same position with the same employer. However, if the employee hired prior to July 1st, 2021 changes their role or seeks employment with a new provider, they will need to become certified under the protocol for new hires outlined in the addendum document. New hires after July 1st, 2021 must meet the minimum education and training requirements outlined in the regulation at the time of hire and be working toward certification after hire. Staff will have 1 year after meeting all PCB requirements to successfully obtain certification. Therefore, depending on the type of certification, level of education, and experience, this expectation should be met between 1 and 4 years after hire. Because appropriate use of the ASAM criteria is reliant upon a working knowledge of the stages of change in motivational interviewing, all assessors and clinicians should have an immediate foundational awareness of this information. This can be obtained through any number of self-selected online trainings, independent reading, facility in-house guidance and instruction, etc. Examples of potential resources for this foundational training can be found in ASAM FAQs previously posted for other levels of care. A record of how this foundational awareness was obtained should be maintained in each employee's training file. However, moving forward, staff will need to obtain the DDAP offered training over an incremental time period. Clinical supervisors are expected to have DDAP approved MI training by July 1st, 2023, and all other clinical staff are to have the training by July 1st, 2026. After 2026, all new clinical staff will be expected to have motivational interviewing training within 18 months of hire, if DDAP approved training was not previously obtained. Over the last 2 years, DDAP has created and piloted a very effective MI training that has both a classroom and an application component that assures participants have a proficiency in applying the MI concepts and principles presented in the classroom training with fidelity. DDAP is ramping up this training availability for wider access and for delivery to occur both in person and through online presentations. Currently, all case management staff are required to take this training, which is why other clinical staff are asked to obtain only a foundational understanding of MI. However, as capacity efforts to provide this DDAP offered training continue to be ramped up over the next year, DDAP anticipates the ability to better meet this training demand after July 1st, 2021, and certainly by the expected timeframes of completion by 2023 and 2026. In the many, if not most instances, SCAs or their contracted providers are conducting level of care assessments and then referring individuals to providers for treatment services rather than the provider delivering the treatment conducting the level of care assessment. This independent process is necessary to avoid bias, as even implicit bias can likely occur. In those instances where a provider of service must conduct a level of care assessment, there will be a process to assure evidence of neutrality when this happens to occur. While additional information will be put out by DDAP's County Program Oversight section regarding this, evidence of neutrality will include documentation that the ASAM level of care assessment has been completed with fidelity, that client choice has occurred, that there is data that indicates referrals to providers other than the one conducting the assessments, etc. DDAP and SCAs will begin to include this in the monitoring tool beginning February 2021. When an individual is being referred to any level of care, with consent, the level of care assessment should be forwarded to the receiving treatment facility to review with the individual and have it incorporated into their record as part of the intake process. Best practice warrants that information is confirmed and validated. In fact, in item number 6 of the Assessment Treatment Plan Review Self-Assessment Checklist, it reads, quote, a provider has a written procedure that a clinician review all admission decisions to confirm clinical necessity of services and that the review is within the clinician's scope of practice, end quote. Review does not mean redo. Instead, the level of care assessment that has been forwarded by the referring agency should be reviewed with the individual, clarified, and even expounded upon if necessary, but not repeated in totality, as such is unwarranted and unfair to the individual. While accurate information is important for clinical assessment, establishing the biopsychosocial and creating the treatment plan, initiation into services should be as person-friendly and considerate as possible. Therefore, whenever unnecessary repeat of information can be avoided without jeopardizing appropriate care, it should be. In fact, Licensing Alert 1-2007 speaks to this issue, and all providers should engage in this person-centered practice of using the level of care assessment provided by the referring entity as opposed to redoing the assessment upon admission to treatment as best practice. DDAP would like to remind everyone that alignment with the service description continues to be a process in which DDAP will offer as much support as possible. Providers are highly encouraged to begin the alignment process now by reviewing the service description document, the self-assessment checklist, and the Pennsylvania expectations document. Providers should begin to identify those areas that require work and create an organizational strategy and plan, including timeframes for completing each of the items on your to-do list, as indicated by the self-assessment checklist. Use the overall timeline that DDAP has made available to gauge how your plan fits into the expected timeframes for alignment. You will see by referencing the timeline that most items will be required to be aligned by July 1st, 2021. Therefore, do not wait until the last minute to engage in the process so that you have time to internally accomplish the necessary tasks, ask questions of DDAP, and if necessary, make adjustments along the way. For those of you who did not already use the chat box to sign in as an attendee of this presentation, please do so by indicating your name, your agency, and your agency's location. For those of you participating by phone, please email your attendance indicating your name, agency, and location to the resource account at ra-daacam@pa.gov. Otherwise, please note that you can send any questions you have about today's presentation to the email noted on the slide. For those of you joining this presentation by phone, again, the email address is ra-daacam@pa.gov. DDAP will be hosting 2 question and answer webinars with the same content on different dates, December 1st and December 4th. You will join the meetings using the Skype link designated for the specific date you want to attend. The links are found on the ASAM rollout schedule located on DDAP's website. We will also do a written FAQ, which will be posted on the website around this same time. While questions will be received anytime, in order for them to be included in the webinars or the FAQ, please submit them no later than November 20th and include Level 2 presentation on the subject line. There will be no certificates of attendance provided for attending this informative webinar. A recording of today's presentation will be available along with the PowerPoint slides by the end of next week. Please watch DDAP's listserv for an announcement regarding availability. This concludes our presentation today. Thank you for joining us.